Good afternoon, good evening, good morning,
One
depending on
second
your
again.
location.
Let me give you the sorry about that. Let me give you the countdown. You're live in 5, 4, 3, 2, 1.
Good morning, good afternoon, good evening, depending on your location. On behalf of ISCH, I welcome you all to ISCH post ASCO EHA webinar on MPN, BPDC, and data from EHA ASCO 2025. This will be presented by our friend, colleague, and well-wisher, Professor Naveen Pembaraju. Professor Pembaraju is a professor in the Department of Leukemia at the MD Anderson Cancer Center. He's a global leader in the field of myeloproliferative neoplasm and BPDC, and he's my favorite MPN clinician. He has authored, co-authored more than 500 publications in the field, and most importantly, holds several leadership positions at the national, international scientific committees on myeloproliferative disorder. He has mentored more than 100 clinicians, including hematology oncology fellows and faculty colleagues in the field. Professor, floor is yours, sir.
Thank you, Professor Bipin Savani, and also to Professor Mohammed Modi and Professor Nagler, and to the IACH team. Thank you all. I see folks joining in the waiting area, Bipin, so this is great. Team, what I would like to do today as I share my slides with you is a threefold objective, which is one, let us together review the MPN abstracts. Two, let us show you the one BPDCN abstract, which I happen to be involved in. And then three, let's put it all into perspective. So with that, let us begin our post-ASCO EHA, MPN, and BPDCN updates. So team, I put together, this is a selection. Obviously, we can't cover every abstract, but I put together a few of the ones that I thought were key and I was able to attend at the ASCO and EHA meetings. So let's go over multiple phase 3 studies in our field. Can you believe it? Really for the first time. So we'll focus on the Verify rusfertide data. This is the first-in-class hepcidin mimetic for polycythemia vera. For disclosure, I am a co-author on this one. Phase 3, the Surpass ET, ROPEG interferon for ET for the first time in decades. We have trials in essential thrombocytosis. This is my colleagues, Dr. Ruben Mesa, Dr. Lucia Masarova, Harry Gill, and others. Then we'll talk about the very exciting novel CALR mutant-directed therapy, the first ever public results, again for ET. This was presented at the EHA meeting. And then we'll talk about a few other phase 3 results, pelabresib and ruxo long-term follow-up, the JUMP study of ruxo with anemia, and then my own presentation of PVEC CD123 for BPDCN. So with that background, Professor Savani and others, I think 2 quick slides of introduction. The reason why we're meeting about MPN in particular is that for the first time in decades, we're starting to approach a next generation of therapy, which I term disease modification. We are moving beyond JAK inhibitor as monotherapy and trying to get into combination, so JAK inhibitor plus a novel agent only, or using JAK inhibitors in previously difficult to treat situations such as anemia. Our theory, as outlined here, is that contrary to the earlier era, can we start to move these therapies earlier in intervention, manage the toxicities, both financial and to the patient, and to bring in immune therapies, including the original immune therapy, Professor Savani, you're expert in stem cell transplant, but also the newer one, immunotherapies such as CALR bispecifics and others. Now, to do this, we have an armamentarium of novel agents, some of which I'm going to discuss here. We made this slide a few years ago thinking that this would encompass the next 10 years, and I'm proud to tell you this slide is already outdated, as we have therapies outside the cell, at the cell membrane, and then in the nucleus, usually borrowed from MDS and AML, now our own therapies. So let's get into it. The first of the 5 or 6 I wanted to highlight. This is the results of the Verify study. So importantly, this is a phase 3 international double-blind placebo-controlled study of a new drug, rusfertide. So this is a new drug that you haven't heard of yet, PTG-300 rusfertide, for the treatment of patients with phlebotomy-dependent P-Veros, presented by our great friend and colleague, Dr. Kirkendall, on behalf of our group. So the rusfertide study featured almost 300 patients, international study, randomized. And in the earlier studies that we were a part of, this is the phase 2, this once a week self-injection, patient gives it themselves, like interferon, for example, you have to have 3 phlebotomies or more in the prior 6 months for most patients. You can stay on your concomitant therapy if you're already on it, but still be needing phlebotomies. And so in the phase 2 was positive study published in New England Journal last year and led to this phase 3. So here you go. So key inclusion, 3 or more phlebotomies in the six months prior. That's pretty phlebotomy dependent, or 5 or more in the prior year. And then you're stratified by your concomitant standard of care therapy, CSC, randomized 1-to-1. So, and as in any trial with this kind of design, half the patients will get the rusfertide, the new hepcidin mimetic, half will get placebo, although here that can mean phlebotomies or whatever standard of care agent you're on, interferon, Ruxo, Hydrea, etc. And then after the endpoint period is reached at 32 weeks, then patients can be crossed over or continued on the rusfertide. Key secondary endpoints are important. So the primary endpoint is to become phlebotomy free when you're so phlebotomy dependent. And secondary endpoint is, can we improve your symptoms, including fatigue, which is a sort of holy grail in this disease. You can see the schema here. So overall, 293 patients randomized 1-to-1. As I mentioned to you, 146 then are in the control group. So that's placebo plus whatever therapy you're on. 50% of patients were on some other therapy. The active group, rusfertide plus whatever you're on. So 146 versus 147, characteristics fairly balanced between the two groups. Remarkably, primary endpoint is highly statistically significant, which is to achieve phlebotomy free by the 32-week period. In addition to that, what about the secondary endpoint? The secondary endpoint was for symptoms, including fatigue. There were actually 4 of those secondary endpoints. All 4 were met. I want to emphasize that all 4 were met. That includes the very elusive PROMIS fatigue score, which at 32 weeks also favored the rusfertide over the control group. Again, the readout meaning that not only did patients achieve hematopoiesis control, phlebotomy independency, but they also felt better doing so. Overall, this is a once-a-week self-injectable agent, so not given in the center, fairly well tolerated. As you might expect, the most common was injection site reactions. Some patients, it worked too well, so then you'll see a little bit of therapy-induced anemia. The most common treatment emergent adverse events after the injection site and anemia are shown here. This was conducted during the COVID-19 early stages of the pandemic. Discontinuation rates extremely low in both groups, 2.7 and 5.5% respectively. Serious events I show you here. There were a few patients who developed skin malignancies, most of them a benign basal cell squamous cell, one patient with melanoma that was actually detected prior to randomization. You can see the other events as shown here. We have found, our group and others, that patients with PV tend to be older, comorbid, and can have other malignancies. Part of that, so it should be followed in every PV group. And so in conclusion, for the rusfertide, first-in-class hepcidin mimetic, self-injection weekly, sub-Q, phase 3 trial was positive for all endpoints, primary endpoint and all 4 key secondaries, statistically significant, presented as ASCO plenary, actually, so this was not just oral. Not only was it achieving all the endpoints, found to be safe and well tolerated with the side effect profile I showed you, and represents a brand new option for phlebotomy-dependent patients with PV. And I want to emphasize that 50% of the patients were already on some agent, still phlebotomy-dependent, and were given on. So it shows a real-world feasible combinatorial program. Now this study will continue maturing, and we hope it can be an option for patients in the coming years. The second study, Professor Zavani and team, I want to show you is in ET. So I just showed you a PV study. Now we have a phase 3. This is safety and efficacy of Ro-Peg interferon alpha-2b. It's also known as Bezremi, Ro-Peg interferon, over anagrelide as second-line therapy for patients with essential thrombocythemia for the SURPASS study. This was presented both at ASCO by Ruben Mesa, then at EHA by Harry Gill. Phenomenal, interesting study. So phase 3 SURPASS ET. So what it is you have to be adult patient. You have to have high-risk ET, which we have criteria for that by 2016 WHO. You have to have already had hydroxyurea and either be resistant or intolerant. That's fair. That's a common standard of care therapy. And then you could not have had interferon, the Pegasus or other interferon before. So you should be interferon naive, had Hydrea, second-line therapy, new drug versus anagrelide. Let's look at the pattern here. So we stratified it based on platelets, which makes sense, symptom score, and your ethnicity. The one-to-one randomization was conducted. The new arm, the RoPEG, is actually interesting. Most of you are familiar with the Pegasus, which is a self-injection weekly. This is every 2 weeks, so just know it's a little bit more patient-friendly. 91 patients here, starting at 250 micrograms, ramping up to 350, ultimately 500 as per dosing labels. And then the control arm is anagrelide, a standard second-line agent we use in ET, 91 versus 83 patients. You can see the treatment forum here, 52 weeks. Primary analysis is at months 9 and 12. Total of 174 patients, worldwide study, including multiple countries from Asia contributing. So it's a new formulation of interferon, RoPEG interferon. Most of you know the side effect profile with the interferons. Let's take a look at that first. So this is 91 RoPEG patients, 81 anagrelide. As you can see here, almost all patients had an adverse event, grade 3 or higher, TEAEs, 23% in RoPEG, but actually higher in the anagrelide arm, 33%. And no new safety signals were seen. Again, most commonly with these, you'll see immunitis, thyroiditis, liver, mood changes, etc. So overall for the SURPASS-ET, this was a positive study. So as a phase 3, you had patients who had a mean JAK2 allele burden decrease from 33.7 to 25.3% at 1 year in the RoPEG arm versus less than that in the anagrelide arm. The primary endpoint was MET Bippin and team, so rate of response by ELN criteria at months 9 and 12. Very positive for the RoPEG, 42.9% versus only 6% in the anagrelide arm. ET-related major thrombotic events and cardiovascular events, pretty low in both arms, 1 and 0 in the RoPEG arm versus 7 and 6 in an anagrelide arm. Interestingly, the RoPEG, the interferon, actually had lower AE-related discontinuation and less serious treatment-related events versus anagrelide. Anagrelide has some issues in the clinic, headaches, palpitations, heart problems, so you do have to watch out for toxicity with that oral drug. And so the readout from this SURPASS-ET phase 3 is that RoPEG demonstrates not only superior efficacy, but also, I would say a bit surprisingly, superior safety versus a pill, anagrelide, as second-line therapy for ET post-hydroxyurea. I expect this to potentially become a standard of care in ET as well, hopefully very soon. So 2 potentially practice-changing studies. A third study we must highlight together, which is in the phase 1, so early development, very exciting, presented by John Mascarenhas at Mount Sinai on behalf of the Insight investigators, which is a new agent, Inca 33989, first-in-class, brand-new drug, mutant CALR-specific monoclonal antibody that is being tested in both ET and MF. Why is that? That's because after JAK2, which is the most common mutation among ET, PV, MF, so it's about 50 to 60% of ET, 56% MF, 100% close to for PV. In CALR is the second most common mutation, and up until now, we haven't had a way of targeting it. So this is very exciting. This was presented at EHA. Let's take a look at these preliminary results. So to remind ourselves, CALR can be a driver in both ET and MF. It is the second most common mutation. You have different types, type 1, type 2, and other. Traditionally, there's some controversy, but ET with mutant CALR can be associated with lower rates of response to treatment and higher risk of transformation, MF compared with JAK2. Some studies differ on that. And the most important thing to know is CALR is a potential immune modulating program. So briefly, it's a mutant-specific monoclonal antibody with Insight Company, has a unique mechanism of action. Again, you have to be able to have a surface molecule that can be targeted. That's the case here. And if you look at the study overall, this had both European and US sites, ET and MF. Here we're focusing only on ET. Remarkably, 49 patients already enrolled, wide-ranging doses from low to higher, median age, as you would expect in an ET population of 60. The drug was found to be safe thus far, interesting and important as a monoclonal antibody in an MPN space. MTD has not yet been reached. Only 1 patient discontinued due to treatment-related emergent adverse events. You can see the serious TEAEs as listed here. Majority of these were grade 1 to 2. So results, remarkable. Hematologic responses are achieved early and sustained in a lot of these patients. In fact, 86% of the patients that received 400 or more milligrams had a response. That's notable. The mean duration of exposure was 26 weeks. And again, only 1 patient discontinued treatment. All others are ongoing at the time of this presentation. At the molecular level, we know from interferon data that you can have molecular responses. And here with this novel mutant CALR, we saw both rapid as well as frequent reduction in both CALR, in the CALR VAF, I should say, so variant allele fraction. So you can see here that 47% achieved 20% or more best reduction in VAF and 21% at greater than 50%. Interestingly, a reduction of 20% or more VAF occurred within 6 cycles of therapy for all 18 responders, and all 18 molecular responders remarkably achieved a hematological response of CRPR. We don't usually talk about CRPRs in ET, but with this program, you're starting to see that. There are other CALR-directed therapies in clinic, including the J&J mutant CALR by CD3, so we eagerly await those results. And there are plans in development for ADCs, CAR-T, and other ways of approaching CALR. So a new, exciting area. One of the take-home points I want the viewers to get out of this, let's follow this closely. Quickly, Bipin, I have a few other abstracts to highlight before Q&A. The next abstract to highlight is that of the BET inhibitor, bromodomain pelabresib. Many of you remember the excitement, navitoclax, pelabresib a few years ago. The navitoclax ultimately showed primary endpoint statistical significance, spleen, but not symptoms, and so that's not currently in development. But the pelabresib remains in development. So this is a frontline trial, pelabresib plus ruxo versus pelabresib versus ruxo alone. So phase 3 frontline randomized international MANIFEST-2 study. These are the long-awaited long-term results presented by Professor Vanucchi, specifically at 72 weeks follow-up, which we have not historically been able to present. So that in and of itself is a feat. So if you look at these results, what you see here is that 67.8%, so 145 of the patients out of the 214 are still on the combination arm, and 72% remain on the other arm. So Pela-Rux arm and the placebo plus Rux arm. So you have a lot of the patients still on study, 72 now up to 92 weeks. And what they did is they're just trying to follow how patients are doing. One question was about transformational leukemia. They found that accelerated blast phase progression as independently evaluated was reported in a low frequency, 6.1% of patients in the Pela-Rux arm, 4.2% in the placebo Rux arm. They compared these two groups and found that the combination arm showed sustained improvements over 72 weeks in spleen response, but also symptoms, SVR35, TSS50, dual response, marrow fibrosis, anemia, etc. Safety profiles seem to be similar and consistent with the earlier updates, and even the leukemic transformation events appear to be decreasing over time, and the two groups appear to be more similar to each other than was previously thought. So overall conclusions from this longer follow-up, survival outcomes continue to show a trend in favor of the Pela-Rux combination. Overall findings suggest that the combination provides meaningful clinical benefits over Rux alone, and they have correlative biomarkers continuing to support evidence of ongoing disease modification. Again, as we started at the top of the hour, we're trying to go for results beyond JAK inhibitor monotherapy. So can you combine a new drug, such as this one, and get deeper and better spleen responses, more symptom improvement, and make it worth it? Can you get more patients to transplant? Can you have patients who live longer? These are the questions we need to answer. Briefly, just a couple more. We do have this nice study presented by Dr. Pankit Bachani of UAB, which is the JUMP study, updated results, which is ruxolitinib more in a real-world community setting, but this time focusing on anemia. This is a problem we get practically in the clinic, and I was excited to see this results. So JUMP, to remind our viewers, was a huge study, 2,000 plus patients, international. It's a single-arm phase 3B, what they call an expanded access study. So basically seeing ruxo in patients with MF in a real-world setting, something very practical and clinically relevant. Here, the investigators wanted to look at patients particularly with anemia and particularly those treated with danazol or ESA, as many of us do in our standard practice. So the question is, when you have Rux and anemia, how do those patients fare? Okay, so out of this large study, about 7%, so 100 of these patients were falling in this criteria: anemia, getting ESA danazol within 3 months. Almost all of them really initiated ESAs, so either EPO or DARBI, and only a few of them, 3 patients, initiated danazol. You can see the characteristics here. Median age is an older population, so 70 plus up to 86, again, representing a real-world clinical population. What did they see? They saw that spleen length responses were comparable between the anemic group, the two groups, so hemoglobin less than 12, and then the anemic group less than 10. They also found that symptom responses were comparable between the higher hemoglobin and lower hemoglobin group. And finally, they found that transfusion requirements decreased, as you might expect, with the addition of the second agents. What does this tell you? It tells you that in a real world setting, older patients, frail, anemia, that you are able to give ESAs, danazol in combination with Rux, and it's not affecting the spleen or symptom responses. You are able to get patients to tolerate doses of the JAK inhibitor, perhaps longer and better. And we know from previous studies that being on the right dose of the JAK inhibitor can correlate with spleen responses and outcomes. So it tells you that a clinical practice that's widely been in use actually is okay, it's safe, and is not affecting the efficacy of the JAK inhibitor. This is a nice study to add. And then finally, Bipin, I wanted to show my own group's results quickly. This is for BPDCN. This is our analysis of the pivekimab, which is the first in class of a CD123 ADC and kind of the second CD123 ADC after the tag that's being tested in patients with BPDCN. This is called the Cadenza study. A lot of the viewers may not be familiar, Bipin, so this is blastic plasmacytoid dendritic cell neoplasm, BPDCN, rare aggressive malignancy, can go to acute leukemia, median overall survival 8 to 12 months in most series. The only approved drug, tag, tagraxofusp, is also directed at CD123, but it has a bacterial modified toxin. Usually patients are older, comorbid, have other cancers. Yes, we want to give these patients intensive chemo, go to a transplant, but most of them cannot do that due to these issues. And so all these patients express CD123. So we asked the question, can this novel agent give clinical benefit? It's a novel drug. It's a new agent. CD123 binding arms, its own cytotoxic payload with this IgN alkylator. And then you have this ADC binding that most of you are familiar with on the CD123 cells. 84 patients overall enrolled, including both frontline and relapse refractory. Out of the frontline, we also included these high-risk patients with prior or concomitant hematologic malignancies, PCHM. It's an IV drug, outpatient, can be given outpatient once every 3 weeks. Key endpoints are shown here, so I'll highlight to you the CR/CRc rate in the frontline de novo patients, and then ORR, OSS, bridge to transplant. So the take-home point of Cadenza, PVEC, 84 patients, 33 of whom are frontline. Of those people, 20 make up the primary analysis population. Here's how they did, including 12 patients bridging to transplant, and the median age is 65 to 70 here, 51 patients in the relapse refractory setting. I show you this in more detail here, older age, 69 to 74, so what you would expect for BPDCN, most having skin involvement, that's the unique part of this disease, half having bone marrow, several of these patients having the PCHM that I mentioned. In the relapse group, it's notable to show how many patients had tag before, so over half of those patients, a third had prior stem cell transplant. So this is the take-home slide. The response rates are shown here. In the frontline de novo, the 20 patients, you have a 75% CR/CRc rate, very good, 80% overall response rate. Relapse refractory group, more modest as you expect for a high-risk group of patients. Overall survival, very, very encouraging, 16.6 months in the frontline setting. This did not matter whether you had de novo disease or the PCHM, with a tail to the curve here. And this is with a median follow-up now of 21.5 months. Transplant helps these patients. We consider it a part of the journey. On the left, you'll see half of all frontline responders went on to go to transplant, and their median overall survival is not yet reached in a historically very poor prognosis disease. This is a big victory for our patients. Here in the relapse refractory setting, although more modest, you'll see among these 6 patients, 30.4 months for overall survival. Adverse events, you have to look at that for any new trial. We did see some anemia, neutropenia, but more commonly was thrombocytopenia in over 1/3 of the patients. Non-heme shown here. Most commonly, we saw peripheral edema, 3/4 of the patients. This is in contrast to the tag, which has a more central capillary leak syndrome. So that's an important point to discuss. Highly manageable and straightforward with diuresis. Infusion-related reactions were next, highly straightforward with steroid management. Overall, it's a fairly well-tolerated drug in the CD123 space. We talked about the peripheral edema. Most patients responded to standard diuretics. Infusion-related reactions, I mentioned, steroids. There were 2 on-treatment cases of VOD, so we need to pay attention to that, particularly at the time of stem cell transplant. And then there were no capillary leak syndrome events. And again, that's to contrast with the tag experience, which did have some percentage of those events. So we conclude with the PVEC, first-in-class CD123 ADC, second CD123 drug targeting for patients with BPDCN, high and durable response rates in the frontline setting, activity in the relapse setting, and a lot of these patients, even though they're older, can go to stem cell transplant. We hope this represents a new practice paradigm-changing shift for BPDCN. Bipin, the floor is back to you.
Thank you, sir. This is so nice summary in short period prep. So, based, you are a very global popular leader. So we have a number of questions. And I
Let's do
don't
it.
think we have enough time to take all the questions. So I have summarized several questions, PV, ET, MF, and BPDCN. So summarizing PV and ET question, what next on PV and ET management? Solid rusfertide data, solid ROPEC data. The question is, what percentage of, let's say both drugs are approved, what percentage of your patient will receive this drug for ET and PV as a first-line therapy?
I think this is important. It really is where we should be talking. So I'll start with ET first, Bipin. ET, we just had such limited options, right? Right now in the clinic, in real life, it's really Hydrea or an interferon. Those are your two real options in the frontline setting. The problem with Hydrea is that we believe that it has not been disease modifying. It can control the counts, maybe help you to prevent a cardiac event. And so if a patient is high risk and they need treatment, we try to give patients interferon in the frontline setting. So the option has really been the Pegasus interferon. I think with the approval of the ROPEG interferon, and we have to see how it's approved, it may give you another option. Again, if it's approved in the second line, fine, or if it's broadly approved. So I think you're going to start to see a shift now that interferons are easier to give. We and the patients understand the toxicity profile, the long-term follow-up, the disease modification. My prediction is we'll start to see a shift away from Hydrea more to interferon and keep Hydrea and Negrelide for later lines of therapy. The second aspect is PV. PV is an interesting one. We've always said there's low risk and high risk, that there's some patients who can be observed. My hypothesis, to be provocative, maybe that's the point of these interactions, is I ask the question, is there such a thing as low risk PV? Maybe with the advent of these new drugs, the new interferons, which are also approved in PV, the ROPEG interferon, and now the rusfertide, if it becomes available, it asks the question, can we treat all patients with PV? Let's suppose you have a young person who's phlebotomy dependent, doesn't quite meet the criteria for Hydrea interferon. Maybe those patients can be treated with the new agent. So I think with PV, it opens the door to more patients being treated, more disease modification. Again, we're trying to prevent bleeding, clotting events, transformation MF, transformation to AML, stroke, heart attack, early death. So let's see. So I would say those are the key things. It gives us more potential options in the clinic, but we still have to address frontline, sequencing of therapies, combination therapies, and in diseases where people are measured in overall survival by decades, you have to make sure not to introduce new toxicities that outweigh the benefits.
No, that's solid. Thank you, sir. So next, several questions summarize myelofibrosis management. So what next in myelofibrosis management? Do we really need combination regimen to improve MF outcome, or any novel agent in development as good as combination regimen?
Ooh, that's the great question to talk about. So I'll answer it in three parts. I would say eventually, yes. I think we're going to get to the point where we're going to be seeing combination therapies as standard. Part two, we're not there yet. As we saw with the initial pelabresib and navitoclax reports from a few years ago, we had successful phase 3 randomized studies that showed that the combination was better than the control, which was Rux alone, but that was only for spleen improvement. It doubled. Both of them were 60+% versus 30%. However, neither of them showed statistical significance for all symptom improvement, and ultimately neither of them are yet approved. Now, the navitoclax we're not currently investigating, but the pelabresib continues on. And so my comment is, I believe that that is really modulating the disease as we saw here. You're seeing the longer follow-up. So I think to answer the viewer's question, Bipin, yes, I believe we're going to ultimately have combinations, multiple to choose from, but we have to show both old world improvements, so spleen, symptoms, whatever you like, but also I think we should show some of the newer markers, PFS, EFS, some of these improvements over time. So can we get to that point? I think we will. We're not there yet. And so I want people to follow these clinical trials, phase 2, phase 3, look at the novel agents, and then let's not forget about stem cell transplant. You yourself are a transplanter. We should be identifying people who are young, high risk to get them to transplant early. Maybe the combinations help you to do that. Finally, maybe that's another goal of combination. Start out on a combinatorial therapy for 3 to 6 months, achieve your best response. If you're a high risk patient or young or fit, boom, you go to stem cell transplant. If you still have persistent disease, early intervention, clinical trial, go to another transplant. If you're having benefit, you either continue on the combination or maybe you drop down to monotherapy, so an induction, consolidation, maintenance type regimen. These are all hypotheses. None of these have been shown yet. I want to give people a sampling of our thinking for the next 3 to 5 years.
We have a number of questions, but I'm going to limit on each disease one question. So last question on BPDCN. So in a responding patient, do you always consider patient for transplantation if patient is transplant eligible?
Short answer, yes. I want to emphasize that even though I'm a non-transplanter, I think you'll respect this too. Transplant should be considered for all patients with BPDCN. I showed you the data here in this one data set. We are routinely taking patients who are older than 65 to stem cell transplant. Yes, it has inherent risks that everyone knows, but all patients should at least be seen by transplant. And let me emphasize 2 points. Patients' performance status can improve in BPDCN with therapy, CD123, non-CD123 therapy. So you may have someone who's PS of 2 to 3 who can go to a 0 to 1. And then 2, there is a thought that maybe auto transplant can be available for some limited cases. We're still working that out. Could it be a skin-only patient, older, frail patient? So I send all these patients to my transplant team for evaluation, not just initially, but remembering that transplant is a dynamic thing. You may not be eligible for transplant 6 months ago, but you may be one now. So see your transplant person early and frequently.
Thank you. Thank you, Professor Pembraju, again for disseminating knowledge to our patients. I wanted to thank all our live audience for the joining webinar and those not able to join. Full recording of webinar will be available on ISCH website. This is in line with our mission of Hematology Without Borders. Anyone can view all past recording anywhere in the world, anytime.
Wow.
Thank you all again, and special thank you, Professor Pembraju. Thank you.
Thank you. Thank you, Dr. Savani, Dr. Modi, Dr. Nagler, and team. Thank you, IACH team.
Thank you, sir.
Bye, guys. Thank you.
Thank you.